All right, today we're going to do something a little different. We are going to simulate one of the most intense situations a surgeon faces, the consultant viva exam. We're going to walk through a classic case from that very first question all the way to the final management plan, just like you would in the real thing. The pressure's on.
Okay, let's jump right in. You've got a 55-year-old patient. They've come in with right upper quadrant pain, and imaging has just picked up a new liver mass. So tell me, how are you going to proceed?
Thank you. Well, my approach is going to be very systematic. It all has to start with a really thorough history and a comprehensive physical exam. These are the absolute cornerstones for building an accurate differential diagnosis and making sure we investigate efficiently.
So in the history, I'm really zeroing in on a few key areas. I want to know about the pain. What's its character? Is it acute? Is it chronic? Any fevers or chills? That right there points me towards an infection, maybe an abscess. A history of recent diarrhea is a huge clue for an amoebic abscess. And I'd have to specifically ask about things like oral contraceptive pills or steroid use, because those are linked to hepatic adenomas. And of course the big ones, any history of liver disease or a primary cancer somewhere else. That immediately raises my suspicion for hepatocellular carcinoma or metastatic disease. Okay, for the physical exam, I'm on the hunt for any signs of chronic liver disease. Things like spider nevi or gynecomastia. These signs can pop up when a failing liver can't properly metabolize hormones, and finding them would suggest underlying cirrhosis, which is a major risk factor for cancer. A tender and large liver could mean anything from an abscess to a fast-growing tumor. You really have to do a complete examination to find these critical clues.
All right, so once I've completed that history and physical exam, I'd move on to the initial workup. This is all about establishing a baseline with some key lab tests and initial imaging.
My first move would be to order a full panel of blood work. A complete blood count, a CBC, might show a high white count, suggesting infection. Liver function tests and a coagulation profile tell me how well the liver is actually working. Inflammatory markers like CRP aren't specific, but they're useful. A hepatitis profile is an absolute must, and so is specific serology for things like entamoeba if I'm thinking about a parasitic cyst. And if the patient has a fever, blood cultures, for sure. Lastly, I'd get a panel of tumor markers, AFP, CEA, and K19-9, to help screen for malignancy.
Very thorough. Now, putting all that together from your initial assessment, give me your differential diagnoses for this liver mass.
So the way I'd structure my differential diagnosis is by breaking it into three big categories, just like you see here: infectious, benign neoplastic, and malignant. For infectious causes, I'm thinking about a pyogenic or an amoebic abscess. In the benign bucket, which includes the most common liver mass of all, the hemangioma, we also have to consider simple cysts, adenomas, and focal nodular hyperplasia, or FNH. And finally, for the malignant lesions, my main concerns would be hepatocellular carcinoma, cholangiocarcinoma, or metastatic disease, which most often comes from colorectal cancer. Okay, let's refine the picture a bit. The lab results are in, the patient has a high fever and a really high white blood cell count. And an ultrasound shows a single, well-defined, dark lesion in the right lobe of the liver.
Okay. This new information, the fever, the high white count, and that specific ultrasound finding, it really narrows things down. The clinical picture is now pointing overwhelmingly toward a liver abscess. So the next crucial step is to figure out which of the two most likely types we're dealing with.
Right, so the key differences are really in the history and the microbiology. A pyogenic abscess, usually caused by bacteria like E. coli or Klebsiella, often seeds from the biliary system, and blood cultures will be positive maybe half the time. On the other hand, an amoebic abscess caused by the parasite Entamoeba histolytica is classically linked to a history of diarrhea. Serology for that is super sensitive, positive in about 95% of cases, and if you were to aspirate it, you might find that classic anchovy sauce pus.
The serology for entamoeba comes back negative, so the diagnosis is a pyogenic liver abscess. Outline your management plan for this patient. All right, now that we have a definitive diagnosis, my management plan is going to be focused. It's going to involve resuscitation, getting the right antimicrobial therapy on board, and most importantly, getting source control.
So, my management plan follows a clear, stepwise approach. First up, resuscitation and starting broad-spectrum IV antibiotics, which we can tailor later once we get culture results back, and that'll continue for about 6 to 8 weeks. Second, for a single, accessible abscess like this, the mainstay of treatment is percutaneous drainage under ultrasound or CT guidance. This gets us source control with minimal invasion.
Surgery, that's step 3, and it's really reserved for more complex situations. And after treatment, I'd be following up closely, monitoring their clinical improvement and getting repeat imaging to make sure it's completely gone.
You mentioned surgical drainage. Tell me, what are the specific indications that would make you escalate to surgical drainage over a percutaneous approach?
Absolutely. You'd move to surgical drainage if there's other abdominal pathology that needs surgery anyway, like a biliary issue. It's also necessary for multiple abscesses or ones that are walled off and just aren't accessible for a needle. Other big reasons would be if percutaneous drainage fails to control the infection, or worse, if the abscess ruptures and causes peritonitis. And finally, you have to remember that what looks like an abscess could actually be a necrotic tumor, and that might require a surgical approach to diagnose and treat. And that wraps up our simulated viva. So now let's zoom out a bit and talk about some other high-yield pearls and common pitfalls related to liver lesions. These are things every surgical candidate absolutely needs to know. Here's a number you just have to burn into your memory: 4.2%. That's the approximate risk of a benign hepatic adenoma turning into a malignancy. And that risk shoots way up for adenomas that are bigger than 5 centimeters. This is exactly why the guidelines tell us to have patients stop taking oral contraceptives and to seriously consider surgical resection for these larger ones. It's a really critical management decision.
And finally, let's end with a classic exam question. What is the most common benign liver tumor, and what diagnostic procedure is an absolute no-go because of the risk of life-threatening hemorrhage? The answer is a cavernous hemangioma, and you should never, ever biopsy it. Knowing that difference is just fundamental. It's one of those pearls that really separates a good answer from a great one. Thanks so much for joining us.